picked up in PET CT scanning. We also have other tracers in PET imaging, and I may mention that PET started as imaging, and now we have PET-driven treatment, where we attach radioisotopes to certain treatment modalities, especially for neuroendocrine tumors and other special malignancies. So we use them to identify tumor in diagnostics, but now we identify tumor and attach treatment modalities to them. We also have perfusion imaging, which helps us to evaluate tumor blood volume, vascular permeability, and sometimes we use this perfusion imaging, especially when there is a bit of lack of confirmation histologically. So people with lung malignancies require brain imaging. I'll not dwell too much. An MRI is usually better than a CT scan, and we're able to pick smaller malignancies. Now, I must say PET imaging is not ideal for brain imaging because our brain cells uptake a lot of fluoride or glucose, and we cannot be able to differentiate. Now, as we follow up patients, sometimes we use some of this diagnostic monitoring to analyze whether our patients are responding to treatment. And sometimes we call what we call NGS, circulating DNA. This circulating tumor DNA started in hematology, where people talk about minimal residual disease remaining in patients who have complete remission. And now we are using them even for solid tumors to be able to determine whether we've cleared the tumor or not. Then, of course, the AI imaging that I've used to describe can also help us predict treatment response. For example, if your tumor had an SUV uptake of 11, and after chemotherapy or a targeted therapy, the size is still the same, but the SUV uptake is 4, that's a sign of a good response. And of course, in analyzing response, we still use the traditional tumor markers. Sometimes if our patients had metastatic lesions, we can be able to pick up. I'll just dwell on some of the staging of lung cancer, non-small cell lung cancer, and we can see the 5-year survival patterns. The earlier the disease, the greater the survival, and you can see that dismal survival of stage 4 disease. However, patients with stage 4 disease with actionable mutations are surviving for years now. So the term theranostics is very common in non-small cell lung cancer, where we use therapeutics and diagnostics to be able to get a personalized pharmacotherapy and be able to sequence some of the treatments. There is also what we call NGS, which helps us to identify epigenetic mutations as well as oncogene driver mutations that have become potentials for targeted therapy. So what happens, we may begin with treating a patient with chemotherapy. There is now combination with immunotherapy, especially for some of the positivities of tumor mutation burden, PD-L1, and so on. And by the way, all those are locally available. Sometimes not in our hospitals, but we can be able to take the tissues to some of these laboratories where they can do that for us. So we are able to do in non-small cell lung cancer what we could do in breast cancer, for example, for HER2 mutations. So that's how overall it looks in the treatment of advanced disease of non-small cell lung cancer. We use chemotherapy as a standard of care. There are now targeted therapies depending on the positive mutations. And of course, we also have immunotherapy.